Welcome back to Health Code Blueprint. Today we're diving into one of the most misunderstood areas of ICD 10-CM. Z codes, the chapter that captures context, status, history, and the why behind an encounter. As the presentation says, Z codes represent reasons for encounters or additional context when a disease or injury is not the primary focus. Quick disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. Before we go any deeper into Chapter 21, it helps to ground ourselves in the purpose of Z codes. At their core, Z codes are all about context rather than pathology. They tell us why the patient is being seen, the reason for the encounter, whether that's chemotherapy, a screening exam, a routine checkup, or documenting history, status, or social determinants. They give us the story behind the visit, not the disease itself. And that leads us to the golden rule. Z codes describe the reason for the encounter, but they are not procedure codes. When a patient comes in for chemotherapy, the Z code communicates the purpose of the visit, while the procedure code captures what was actually performed. In other words, Z codes explain the clinical intent, and the procedure codes document the action. Next, we look at sequencing. Some Z codes must be first listed, like Z00 for general exams, Z38 for live-born infants, and Z51.0, Z51.1 for radiation and chemotherapy. Others are conditional, like screening or observation codes. And some can never be principal, such as Z37 for outcome of delivery or Z16 for drug resistance. This slide walks us through Z00, Z02. These are used when the patient is essentially well but needs a checkup or administrative exam. The slide notes, do not use if the exam is for a specific diagnosis or symptom. If findings are abnormal, we code the abnormal findings as additional diagnoses. Here's where coders often get tripped up. Screening is for people who appear well. Observation is for suspected conditions being ruled out. The slide explains, screening, Z11, Z13. Observation, Z03, Z05. Suspected condition ruled out. If the patient is symptomatic, it's not screening, it's diagnostic. Aftercare codes, Z42, Z51, are used during the healing or recovery phase. The slide gives examples like closing a colostomy or removing pins. It also warns, do not use if treatment is for a current, acute disease. Do not use for injuries. Injuries use the seventh character, D, instead. Once the condition is fully treated and no longer exists, we move to follow-up codes Z08 and Z09. The slide states, condition has been fully treated and no longer exists. These are always followed by a personal history code, such as Z85 for history of cancer. This slide helps us distinguish between status and history. Status means the patient currently has a device, sequela, or residual condition. History means the condition is gone but still clinically relevant. The slide notes, redundancy rule. Do not use if the diagnosis code already implies the status. Here we get into specifics. BMI, Z68, only assign with a reportable diagnosis. Machine dependence, Z99, sequence chronic respiratory failure first. Z16 for drug resistance, always paired with the infection code. Genetics, Z14 for carriers, Z15 for susceptibility. This slide highlights three types of encounters that often look similar but serve very different purposes. Exposure codes are used when a patient may have come into contact with an illness or environmental hazard and needs evaluation. Inoculation visits are for immunizations, and while Z23 captures the purpose of the encounter, the specific vaccine is identified with a procedure code. And prophylaxis codes are used when a patient receives preventive care, such as a surgery done to reduce future risk, and these are reported first because prevention is the main reason for the visit. For the mother's record, Z34 is only for strictly normal pregnancy supervision. Z37 is always secondary. Z3A captures weeks of gestation. For newborns, Z38 is always the principal diagnosis. Z05 is used for observation when a suspected condition is ruled out. This is one of the most important slides. It highlights that SDOH codes can be assigned based on documentation from non-providers. The slide states, unique rule, SDOH codes can be based on documentation from social workers, nurses, case managers, or patient self-report. These codes capture unmet needs like food insecurity or housing instability. These codes help capture encounters that focus on guidance, support, or non-disease-based needs. Counseling codes apply when the visit centers on services like contraception, genetic counseling, or dietary and travel advice. Donor codes are used only when the individual is a living donor, such as someone giving blood or tissue. And lifestyle or management codes are assigned only when the documentation clearly shows the patient has a related issue that needs attention. Non-specific Z codes should be used only when there truly isn't enough information to assign something more precise. The guideline notes that there is little justification for non-specific Z codes in an inpatient setting, because those encounters usually have more detailed documentation. These codes are really meant for situations where no further detail exists, typically in outpatient visits. The final checklist brings everything together and gives you a quick way to confirm you're assigning Z codes correctly. It walks through the key steps: identifying the intent of the encounter, checking whether a procedure code is needed, verifying sequencing, distinguishing aftercare from follow-up, avoiding redundancy, and remembering to capture SDOH when documented. It's a practical summary you can rely on during everyday coding. Thank you for watching, and I'll see you in our next video.